Okay, I think we can start. Welcome, everyone. This session entitled Restratification and Outcome, What Every Surgeon Should Know. It's been designed to provide surgeon insight into statistical model and way of reporting outcome, which can be, understood by everyone. We have the privilege of great speaker today, and I would start straight away with Professor Rumana Omar. She's a professor in statistics at the lead of the statistical group at the UCL. She's also the advisor for NICOR, and she will give us a talk on statistical methodology for outcomes monitoring explained to surgeon.
Hello, I'm Rumana Omar. I'm a professor of medical statistics in UCL. I will talk about, or I'll give an overview of statistical methods that are used to monitor clinical outcomes of health providers. A quick background. National bodies monitor the performance of healthcare providers to maintain and improve the quality of care of patients. And typically, by healthcare providers, we mean hospitals, clinicians, or surgeons, and I'll refer to healthcare providers as units in my talk. So the units are monitored with respect to a performance indicator, such as in-hospital mortality, following medical care, or a surgical intervention. For example, it may be of interest to compare hospitals in England and Wales with respect to their in-hospital mortality following adult cardiac surgery against a nationally set benchmark. The monitoring results are then made available to the units, the policymakers, etc., to manage and handle the outliers. So what do we mean by outliers? So the purpose of monitoring is to identify those units whose performance substantially diverges from a target value. The target value is pre-specified, and it can be the average performance of a group of units, which is derived from the data, or it can be externally set. Then the units which substantially diverge are called or are termed as potential outliers or potentially unusual units. And depending on the degree and direction of the divergence from the target value, the units can be classified as normal, alerts, or alarms, with alarms meaning that the units show a larger deviation in performance from the performance target value. So when we are monitoring performances, or when performance of units are being monitored, there will be differences, and ideally these differences represent mainly random variation, that is, variation due to chance. In addition, there may be true differences in the performances. However, performances may also vary across units because of the differences in the characteristics of the patients which the units treat. And this is termed as case mix of the patients. For example, if the in-hospital mortality following cardiac surgery is being monitored for hospitals, it could be that the risk profiles of the patients vary across hospitals. Therefore, hospitals which treat high-risk patients on average, may have a higher proportion of in-hospital deaths when we calculate the crude mortality. However, it's important that the monitoring is done in a way so that hospitals are treated fairly and hospitals which treat more severe patients are not penalized. And therefore, we always recommend that monitoring should be based on risk or case mix adjusted outcomes or performances where it is possible to do so. Now I'm going to describe the statistical steps that's involved in detecting outliers. So first, a performance indicator is selected and then suitable data source identified, data obtained, the time period is set, and the target performance value is specified. Once all of these things are done, then we would like to calculate the risk-adjusted performance measure. By that, I mean that what we would like to do is actually estimate the predicted risk for each patient using a suitable risk prediction model to adjust for the differences in the case mix of patients. For example, if we are monitoring the mortality following cardiac surgery in hospitals, we might want to use the Euroscore 2 risk model to adjust for patient characteristics. Typically, it's important that a model is chosen which has been externally validated and has demonstrated good predictive performance. Typically, modeled performance is measured by how well the model can discriminate between low and high-risk patients and how well the model can predict the risks for patients, which is termed as model calibration. Sometimes risk models are not available. In such situations, it's important to use or identify the characteristics of patients that's available in the routine data that is being used for performance monitoring. For example, gender and age should be available, and gender and age therefore should be used to adjust for case mix, at least for the minimum adjustment. Now, the National Institute for Cardiovascular Outcome Research, NICO, is commissioned by the Healthcare Quality Improvement Partnership funded by NHS England to use data collected from hospitals over a pre-specified time period to produce audit reports for mortality of performances for some of the clinical domains, such as adult cardiac surgery, arrhythmia, congenital heart disease, myocardial ischemia, heart failure, and PCI. Now I'm going to describe the methods that are available to detect outliers. First, I'll describe a simple method, which is known as the common mean model. This method is simple. It assumes that there is a single underlying true performance. For example, it could be an average performance, or for binary outcomes, dead or alive, it could be the overall proportion. And it assumes that there's an overall true proportion that underlies all units, that each unit has the same performance, and any variation that we observe in the performance between the units is random. It's totally by chance. A visual representation is made of the performances. The performance indicator is plotted against its measure of precision. For a binary outcome, that could be the risk-adjusted proportion of events plotted against the sample size. Then limits are constructed around the target value to reflect the range of acceptable variation at a pre-specified statistical significance level. For example, 95% and 99.8% limits are constructed, and they correspond to testing whether the unit is significantly different from the target value at two-sided p-values of 0.05 and 0.002 respectively. The target value is usually represented as a horizontal line in the graph, and the units whose performance lies beyond the limits of acceptable variation are considered as potential outliers. So we have an example plot here. On the x-axis, we have the number of clinical procedures, which is the sample size. On the y-axis, we have the risk-adjusted mortality proportion. And this is a funnel plot. And the blue line here presents the 95% limit of acceptable variation, and the red line represents the 99.8% limit. And we can see here that institution 26 and institution 25 and 11 are outside the blue line here and can be considered as alerts. Institution 2 is outside the red line and therefore can be considered as an alarm. The problem with this method is that there could be a case of overdispersion. What overdispersion means is that when the variability in the performance measure and the outcome is higher than expected by chance. And this can typically arise when there's insufficient risk adjustment. For example, there could be unit level factors that vary and that can contribute to the excess variability, which are not so important for the outcome or the performance themselves, but it does vary across the units. Or it could be that the risk models we are using do not sufficiently correct for the difference in the case mix of the patients. For example, if a unit treats patients from a certain ethnic group more often than other units, and that ethnic group is associated with the higher chance of dying, then if the risk model does not include ethnicity as one of the risk factors, then we would have insufficient correction for case mix adjustment. Therefore, if one is not careful, then some units can be labeled as significantly different when it's really the overdispersion problem. So random effects methods have been proposed to handle overdispersion, as these methods can account for unmeasured factors that can lead to systematic differences between the units, and the overdispersion is kind of inherently dealt with random effects methods. I'll first describe a method which uses unit level data. There's a random effects method, and so it's the patient data aggregated for each unit. This method assumes that the underlying true performance, for example, the mortality rate, does vary across the units. So there is a variation between the units. It's not equal. And the between unit variance can be estimated. It is estimated using a quantity called tau squared. It assumes a Poisson distribution for the observed number of events, which is then approximated by a normal distribution. In the visual plot, the y-axis represents the ratio of the observed to the expected for each unit, and it's plotted against a measure of precision, which is typically the expected number of events. And the target value is taken to be the ratio of the overall observed divided by the overall expected number of events, and that is represented as a horizontal line. And the between unit variance tau squared is incorporated in the calculation of the acceptable limits. So here's an example of such a plot. Here we can see that the observed over expected ratio is plotted on the y-axis and the expected value on the x-axis. And we have our 95% and 99.8% levels or limits of acceptable variation. And here actually what we can see is that unit 16 is doing better than the performance value, and the target performance value, and unit 6 is doing significantly better than the target performance value. Finally, I'm going to describe another approach which actually uses the individual patient level data. So here, the performance or the outcome is binary. So whether, for example, the patient dies or is alive. And therefore, we use a logistic regression model for the binary outcome. However, the logistic regression model has a random intercept, which allows the intercept to vary across the units. So what we have here is the alpha is the overall log odds of dying, let's say, and that we add this term, which is the UI, which represents the unit-specific deviations from this overall alpha. So each unit is allowed to have its own UI or own intercept, okay? And the XIG are the predictor values for the jth patient in the I8 unit, and beta is the regression coefficient, estimating the association between the predictors and the outcome. And the proportion of the events or the risk-adjusted proportion is calculated by transforming the UIs from the logit to a probability scale. And typically the units are plotted on the y-axis and the proportions on the x-axis. The plot includes a vertical line at the target value. If the target value falls outside the limits, which are represented by horizontal lines, then the corresponding unit is termed as an outlier. So this is an example. So here we have this vertical line, which is the performance target value. Then the square, the rectangle here is the observed mortality for each hospital. And the cross here is the predicted mortality. So after applying the external risk prediction model, what is expected. And the round circle, filled in round circle, is the risk-adjusted mortality for the hospital, which is the transformed random effects that I've talked about. And what we can see, for example, for hospital 1, that the predicted mortality is actually lower slightly than the performance value, which means that the hospital probably treats patients who have a relatively lower risk profile. However, it is not an outlier. And we can see again that hospital 6 or unit 6 is doing substantially better. Now, which Outlast detection method should we use? The common mean model is simple, but it does assume that the performances vary between units just by chance, and that may be unrealistic. It can lead to identification of too many outliers. It will need an adjustment of over-dispersion, which can be estimated from the data. The random effect methods can inherently deal with over-dispersion and relaxes the assumption of random variation. However, the Poisson assumption that is made for the unit level approach may be too simplistic, as performance indicators are typically binary at the patient level. The individual level random effects model can easily accommodate risk adjustments based on an existing risk model, and we can also add additional unit and individual level risk factors if they're considered to be appropriate as explanatory variables in the model. It better describes the underlying model that generated the data, because as I said, it's a binary outcome rather than a Poisson. And however, it may be more complex to implement and visualize. Just wanted to make a point, if the variation between units is small, these methods will produce the same results. So there are some challenges. Clinical practice changes over time. For example, new treatments may be introduced. So risk models may need to be reviewed, the performance of the risk models periodically, and if necessary, these models need to be calibrated or redeveloped as necessary. The other problem is that we estimate the variance between units, but these estimates may be unduly influenced by a few units with extreme performance, thus masking the detection. Therefore, we would need to use an approach to alleviate this problem. For example, one could use Windsorization, which downweighs the extreme units. When the number of units under comparison is large, then some units may be identified as outliers just by chance, and that is the problem of multiple statistical significance testing. To apply these methods, we need adequate sample size. For example, we would need at least 200 patients roughly per unit. And we have to make sure that ensure that the sample size assumptions hold. We might have to drop units where this doesn't hold. Quality of data, as you understand, is very important. And if you have large proportions of missing data in some units, that is problematic. The other point, the final point, is that it's not really a challenge, but a statistical analysis plan should be written beforehand, which specifies all the important details so that any outlier results that are produced are reproducible. Thank you.
Uday, I think we can't hear you. Maybe you will have to unmute.
Is that better? Sorry.
Yes. Perfect.
Okay, sorry, yeah, okay. Well, first of all, I'd like to thank Professor Omar for that great talk on explaining the new methodology that's being used by NICOR across all the audits. Question and answers will be at the end of this session, so we'll move on with our next talk, which is on public reporting of clinical outcomes, its importance and relevance to the future. It is meant to be delivered by Professor Benedetto, but as you can see, he's in a much sunnier climate of Italy than we are. So it will be delivered by his cardiac research fellow, Arnaldo Di Magli. I welcome him to present the talk, please.
Hello, my name is Arnaldo Di Magli. I'm a research fellow in cardiac surgery at the University of Bristol. Together with Professor Benedetto, I would like to thank SCTS for the opportunity to give this talk about public reporting of clinical outcomes, its importance, relevance, and future. So what is public reporting? Public reporting means measuring, monitoring, and publicly reporting of data on quality and clinical performance of hospital and doctors. This means, for example, reporting on the mortality rate after an index procedure for each hospital and each surgeon. An historical review of public reporting in the UK sees the start of the first public report in 1860s with Florence Nightingale, which compared the mortality rates among the different London military hospitals. After almost 2 decades, in 1980s, data on hospital performance in England and Wales were released publicly, but this was still not fully public report as it is intended now, because this was more intended for managerial rather than public use. In 1998, there was the first release of a high-profile national report in the UK. And finally, in 2004, after the Bristol Inquiry, ACTS started publishing postoperative mortality rates for cardiac surgery first at a hospital level, so by unit, and some years later at the individual surgeon level. Why is important public reporting? First, it improves transparency. Secondly, it increases accountability of healthcare providers. Thirdly, it informs patients' choice, and this helps patients to mature their idea, their clinical decision in a more independent way. Fourthly, it maintains standard and or promotes improvements. What are the advantages of public reporting? There is an improvement in the quality of care at the hospital and individual provider level. There is increased attention to quality improvement strategies. There is improvement in healthcare delivery and clinical outcomes, such as mortality and patient experience. And there is benchmarking individual and hospital performance as a feedback loop to stimulate further improvement. This is a very interesting report published on JTCVS Open in 2016 about the mortality trend after cardiac surgery with data from the National Acute Cardiac Surgical Audit dataset. So we can see that from 2002 to 2016, the mortality rate in cardiac surgery dropped from 4.0% to 2.8%. As the authors have acknowledged in their paper, this cannot be merely attributed to public reporting, but we can certainly dispute that public reporting had an important impact in guaranteeing these better outcomes. These are the examples of how SCTS public reports on the surgical outcome after cardiac surgery. So we have a plot for the hospital outcomes and one for consultant, but they are pretty the same. In each plot, there is the observed mortality, the predicted mortality according to the Euroscore, and then we know if the observed mortality is within the limits, if it's alarming, so survival is worse than expected, or if it's significantly higher, so there is a higher survival than expected. Another way of public reporting is funnel plots, which are these, where we find the horizontal line, which is the predicted survival for hospital or surgeon case mix, the expected survival rate. So when the observations are within the margins, the upper and the bottom and the lower margin, they are expected survival rate. And then we have the outlier. So those observations which lies beyond the margins, in particular those which are beyond the higher margin are mortality higher than expected. This can be due to adjustment, risk adjustment not properly performed for the specialist practice. This can be due to chance itself, or it can be due to poor quality outcomes. This is instead an example of report cards provided by the Society of Thoracic Surgeons. And in particular, here it's very interesting that a patient can understand and can clearly see in a very straightforward way how the hospital performed through this 3-star based method. So if the hospital for the mortality has 2 stars, it means that the mortality in that hospital is as expected. If he has 3 stars, it means that it's better than expected. If he has only 1 star, it means that it's worse than expected. Of course, when we are dealing with public reporting, we face numerous of challenges. The first one is risk adjustment. So we have risk model performance. We need for a model with stable estimate throughout the spectrum of probabilities, so that underestimation and or overestimation of the risk is absent. Secondly, risk model. Hierarchical multi-level models should be preferred of a logistic regression model has to account for the clustering effect of patient by surgeon and surgeon within institution. Another challenge is data quality. Of course, collected data have to be accurate and consistent. Collected data have to be as complete as possible, and there must be in place highly standardized methodologies to impute missing data. Then the validation of collecting data and auditing of collecting data. Third, the sample. Clearly, to understand if the performance of a hospital or of a surgeon is within the expected rate or is worse or better than expected, we have to meet a statistical power, which is the consequence of the procedure performed in the hospital or by surgeon. So hospital and provider with low number of index procedure represent a problem from a statistical power point of view. And for this reason, the SCTS only included those surgeons who perform at least 100 procedures for the time period considered. Also, with a low number of procedures, we have a problem with a low rate of outcomes, which can inflate the rates of mortality, for example. And secondly, and lastly, the identification of outliers. The presence of an outlier not always means the presence of a worse performance, because the outlier can be the consequence of the case mix of the data quality. Lastly, but not least important, challenge is intelligibility. So data, analysis, and plots should match the health literacy of the public in order to be understood, interpreted, and properly used to make informed decisions. Misinterpretation often happens. In this way, no evidence of poor performance does not equal acceptable performance. Of course, with public reporting comes also some adverse effect. One of these is risk aversion. So surgeons may be more reluctant to operate on high-risk patients, preferring low-risk patients so that they don't jeopardize their performance. Data gaming, it's surgeons themselves who put in the data inside the dataset. So there can be a manipulation of the predicted mortality risk as to increase the expected mortality. And finally, the training. There could be a reduction in the number and variety of cases performed by trainee, because consultant surgeons may want to preserve and to protect their overall performance, fearing that giving the case to the trainee may be associated with the worst outcomes. And finally, which is the future of public reporting? Of course, we need to maximize patient benefit from public reporting. We need to have a wider and clearer spread of public reports. And we need to move beyond survival rate. So we need to find new quality indices, such as post-operative morbidities. And finally, improving data collection and analysis. I thank you for your attention.
Thanks, Uday, for your introduction. I'm going to move on to the next presentation. We have the privilege of having Professor Rakesh Arora with us from University of Manitoba. I was just reading he was born in London, but actually not London in the UK, but London in Canada. And Professor Arora is a cardiac surgeon, but also is an expert in also intensive care with a very busy academic background. His talk is on improving mortality outcomes monitoring, a US approach, phase of care mortality analysis. Please.
Hi, my name is Rakesh Arora. I'm a cardiac surgeon and intensive care medicine specialist at the University of Manitoba in Winnipeg in Canada. It's with great pleasure and honor that I have the privilege of discussing this topic with you today on improving mortality and outcomes monitoring, a U.S. approach for phase of care mortality analysis, or POCMA. I have these disclosures, which have no direct interaction with this talk. I always like to start with my thank yous up front. And again, thank you very much to the Virtual Planning Committee for the privilege of discussing this and a few other talks through the course of your meeting over the next few days, as well as to Daisy Sandeman, who I've known for a few years through my work on delirium with her and some of the people at Edinburgh. And thank you very much for the link to and allow me to be part of this meeting for this occasion. Last year I was meant to be there in person, but for obvious reasons, we weren't able to meet. And now again, the opportunity to present virtually today. I will also disclose that I'm a Canadian. I'm actually not from the US, and where I'm from, you can see is right in the middle of Canada, which ironically is also the geographic center of North America. But I don't live in the United States. There actually isn't a formal mortality analysis protocol that's accepted nationally in Canada, nor really in the United States, but we will talk about the phase of care mortality analysis and a little bit later on about the failure to rescue metric that is being adopted in several regional consortiums in the United States. So I'll modify again, take out the US and just talk about the phase of care mortality analysis for this talk today. I will also disclose that I am not a quality expert. I am a strong enthusiast. I will be probably sharing some information with some of you who actually may be experts in this field, but we'll also be taking some slides from some colleagues of mine who are proper experts in quality improvement and sharing some of that information and data with you as we go through this. Two of those people I'd like to acknowledge up front is my predecessor, Dr. Alan Menkes, who was the chair of cardiac surgery here before he handed the reins over to me, and Dr. Ivan Zelentsov, who is our senior resident, who's actually graduating this year, who's done formal training in quality improvement and actually going to the UK for a fellowship later this year. Lastly, I'd like to thank my team. This is the cardiac surgery team shown for you here on the left side of your screen, our ICU team, or part of our ICU team anyways, on the bottom right, as well as the hospital where I work in. This team has generally made my job a great deal of fun and very easy because they are interested in doing the right thing every day by our patients. So introducing new concepts and quality improvement measures, they've really jumped on board with and have been part of the process rather than being a sideline player for a lot of this, which is really important. This idea of team and multidisciplinary care really is at the forefront of what we're going to talk about today as we go forward. Taking this concept from Mr. Joel Dunning about putting the most important slide up front, I'm going to use the same shamelessly here as well. And if you take nothing else away from this talk is that we have to be able to apply quality and safety to our patients 24 hours a day, 7 days a week. Whether you have different house staff at night or on weekends, the processes need to be in place to be able to protect your patients from harm. And we'll go through how phase of care mortality analysis may help set up those processes for your team, again, depending on your actual human resources available at different times during the day or the week. To frame this conversation, we'll start with a briefcase example. I'll provide some more information about why quality and safety is important for the cardiothoracic patient and how to get started with your team. Okay, let's start with a case example. You have a 73-year-old gentleman that's been referred to you for cardiac surgery. He was initially seen by a colorectal surgeon for a sigmoid mass that requires operative resection. During that workup, it found out that he has a cardiac murmur, subsequently worked up to have by his cardiologist to have critical aortic stenosis with concurrent coronary artery disease and referred on to you for surgical intervention as he does not meet the criterion for a TAVR at your particular institution. As you go through your workup in your clinic office, you find out that his symptoms have been progressive over the last few months, where he has increasing shortness of breath on exertion, less than 2 flights of exercise tolerance at present, some peripheral edema, and the very beginnings of orthopnea. So he is an NYHA classification 3-ish of heart failure, but he does have a preserved ventricular fraction, left ventricular fraction, but does again have critical aortic stenosis and coronary artery disease. At our institution, prior to their surgery as an outpatient, they come through a pre-admission clinic where they're more, again, extensively reviewed by the clinic nurse and nurse practitioner, as well as the anesthesiologist. Despite meeting with the cardiothoracic surgeon just a week prior, where he'd gone through the details of the procedure and so forth, it's clear he seems a bit befuddled when he comes in that particular day. He doesn't know why he's there per se, other than maybe perhaps a check for his heart, and doesn't require all the conversation that was had before. We invited a family member to come in. We redo the conversation and consent them appropriately for surgery there afterwards. When plugging in his risk then into a Euroscore, which you may use there, we use Euroscore here at our center. The STS score similarly would give you similar risk overall. When you plugged in the values of this particular 73-year-old patient into this calculator, you'll find out that he's in the relatively lower risk category with a predicted operative mortality of 3% or less. So therefore, he undergoes the magic of cardiac surgery with a bioprosthetic aortic valve replacement, as well as a 4-vessel bypass. We found a diagonal we could graft, so we did so as well. He returns to the ITU thereafterwards. Unfortunately, upon lightening sedation, he's thrashing around wildly. This is despite appropriate narcotic and dexmedetomidine to help emerge him slowly. He's put back to sleep again with some propofol, sent to the CT scanner to rule out there being an acute brain lesion. Nothing's found, which is often the case, and an immediate CT is done after cardiac surgery. He was brought back to ITU. Unfortunately, upon arrival back to his unit, he self-extubates himself and still thrashing about wildly. As a response then, because he's now unsafe to himself and to others, he gets some lorazepam, he gets some more narcotics, then he gets a lot of Haldol, and now he's no longer agitated. He's in fact the opposite, where he's now sleepy and then becomes hypoxic. And unfortunately, he aspirated during this and then has to be re-intubated, and then a host of problems happened there afterwards. He remains mechanically ventilated for the next 5 days, gets extubated and re-intubated twice because of weakness and poor ability to clear his secretions. He eventually requires a tracheostomy and unfortunately then develops a ventilator-associated pneumonia about a week and a half later, complicated by significant sepsis, acute kidney injury, multi-organ system failure, and eventually expires 40 days after his admission to hospital. So this is an example of a patient who came in as an elective procedure, who, again, going through a story, may have had more vulnerabilities than just the Euroscore 2 would allow us to identify, that led to a series of events that ultimately led to his demise afterwards. So we can say in this case was not a great example of how we won in an elective cardiac surgery patient. So looking at this information, it's clear that there is a problem, and there's only one particular area that could have been attributed fault. There were probably fingers being pointed at on this particular case at different time points, but in essence, this is a system problem, and we all need to figure a way that we can mitigate risk in these patients going forward, and we'll talk a little bit more about that next. So it's clear, and this is a great slide from my colleague Rizwan Manji to put this together to encapsulate this concept. As a healthcare system and taking care of these very complex patients, we're capable of great feats. These are some examples from the space aeronautic industry, obviously, but by way of analogy, we can accomplish great things when we put together teams together to create excellence. The difficulty is errors will occur, and as humans, we often have these errors occur in very predictable ways. Importantly, even the smallest component can lead to system failure. And without there being the appropriate redundancies and an identification of where vulnerabilities can occur, we're prone to make these mistakes over and over again. And importantly, though many of us don't like to admit it, 100% of us will make a mistake at some point in time, and this will lead to negative outcomes in our patients. So why is a cardiac surgery patient at particular risk? Well, we really have this dichotomy of patients, don't we? We have those patients who can be deemed lower risk or healthy, if you will, using traditional metrics of evaluation, compared to those patients who are at higher risk with multi-organ system dysfunction coming in, perhaps high rates of frailty, high levels of comorbidity. And while our attention as a team tends to focus more on the high-risk patients, and appropriately so, the large majority of patients still, for most of us anyways, is in the lower risk group of patients. And therefore, they represent the highest risk of patients, highest number of patients at risk of harm. This can be then further identified as why that's important from this article now about 13 years ago from a group from Ontario in Canada, where they examined 350 deaths over 11 centers in Ontario. They were looking at the reasons for death following isolated coronary and bypass grafting, and they chunked these up to three broad categories: those that were deemed to be preventable, not preventable, or maybe preventable. When you categorize the maybe preventable and preventable deaths, this occurred in about a third or more of patients, and a large number of these were in the post-operative phase. So not in the intraoperative phase, but the post-operative phase in the ICU. Importantly, when you look at that dichotomy again of the high versus lower risk patients, the majority of preventable deaths occurred in the lowest risk patients, so those with an STS or Euroscore less than 3. And part of this may be driven by an inappropriate decision to operate in some of those, which again, we can argue about in this particular case as well. So while this information is very helpful to identify the various reasons for why this occurred, such as communication errors, process errors, or education errors in the ICU or in other phases of care, it doesn't really drill down the reasons for why it occurred per se on an individual patient and what we as a team can do to mitigate that risk going forward. So take this concept then from Edward Deming, who's really the father of quality improvement in industry in general, along with Walter Schuchart, really just developed this concept of the plan, do, study, act sort of paradigm we use in quality improvement now, using management theory. And there are 14 steps that Deming describes, and I won't go through all those in detail right now, but the two important quotes that I think I've shown for you on the screen here that really drill home this point for us in healthcare. And I can distill it really down to just one sentence. That's that we have to measure what we're doing. Without appropriate measurement, knowing what you're doing right and what you're doing wrong, it is hard for your team to improve. And rarely is it a single person in the vast majority of cases that are the cause of this. It's a system process problem that involves the entire interdisciplinary team that needs to understand how to do business better together. So going back to this concept then of how we can distill out the causes of mortality in the various phases of a patient's journey, this has been best described initially by the seminal article by Francis Shannon from the Michigan Cardiac Surgery Quality Improvement Initiative, where they linked together a number of centers and looked at mortality and divided up into 5 phases. And the key principle here, again, is that there are a number of events that are interconnected through the entire patient journey. And often the root cause of someone's ultimate demise can be traced back to a seminal event. Now, that event in itself may be important enough to cause mortality, or may lead to a cascade of events that occur there afterwards that leads to ultimately the death in the particular patient. And in these 5 phases, there's a preoperative phase, intraoperative phase, which again, we tend to focus most of our attention on where mortality occurs, postoperative phase, on the ward, in the ICU, as well as upon discharge. Importantly, again, much like the previous study I've shown you from the Ontario group, that a large majority of mortality can occur in the postoperative phase, particularly in the ICU, with failure recognition of decompensation or a catastrophic event, which I'll talk about later on, that can be categorized or classified as a failure to rescue. Importantly, the other 4 or 5 phases are equally important, but of all those, the majority of deaths occur outside of the OR when you look for the various reasons for why these occur. Again, a large majority of these also occur due to preoperative evaluation, and again, we'll go into a bit more detail about this in just a moment. So looking in the phase of care mortality analysis, we can divide this into 2 phases. There can be those where there's a lack of identification of treatment plan, medical decision-making, or decompensation, or those where there's an unexpected fatal event that leads to a catastrophe or death that's also called failure to rescue. Again, much like the Guru paper from Ontario, the majority of these deaths occur in the most lowest risk group overall, not the high risk group, again, where our team tends to focus most of our attention. Again, when looking back at this phase of care analysis, it's really a seminal event with a specific phase of care that either in of itself can cause death or culminates on a series of events that eventually leads to the death of a patient. So when looking at this patient in particular then, one could look at the preoperative phase as where the vulnerability should have been identified, perhaps to modify our decision-making both in terms of timing or even the procedure itself. When looking back at this patient with a retrospectoscope, you can tell perhaps that this patient has some degree of cognitive dysfunction. And if one were to investigate more comprehensively, perhaps he would have identified some degrees of frailty due to poor nutrition, due to his underlying oncologic condition, led to some slowness and other difficulties that led to lack of optimization coming to the operating room, and also a higher risk for delirium, which is what he actually experienced in the postoperative phase. So in terms of the cardiac risk factors, non-cardiac risk factors are certainly important, but also timing in terms of judgment of risk versus benefit, whether invasive versus a less invasive procedure would have been more appropriate for him, or other things we could have done to optimize the patient, or perhaps not even optimized, or not even offered a surgical procedure at all and opted for medical therapy. To address all these vulnerabilities in the patient, there's these new guidelines that have come out now 2 years ago from the Enhanced Recovery After Cardiac Surgery Society. Again, I won't go through all of these in details, and we will talk a bit more about this in some of the talks that come up later in this meeting. But this is an important document for you to consider of how to address these preoperative, intraoperative, and postoperative vulnerabilities if you identify a sentinel event for why it's occurred. But the crux of both Deming's work and the work done by Shannon and several others in this area of mortality analysis is data. You need to collect data in order to understand where the issues are occurring and then develop processes to adapt your system or your team to mitigate those risks. Now, this can be done at the institutional level, which is often the most important way to start, but this also can be done on a larger scale. So this is now going back several years with O'Connor, initially from the Northern England group, and this important article from last year from Alex Irabarni from also the Northern New England group, where they looked at the 30-year data of a regional consortium on quality improvement in cardiac surgery. Again, if we focus just on isolated CABG, because that is still the most common procedure we likely do in most of our centers, they found when looking at the late 80s and early 90s that there was a fair degree of variability of mortality after cardiac surgery, particularly isolated CABG. So going back through various phases of improvement, training, process mapping, and data collection with feedback. And the last part is also important. Collecting the data, analyzing it, and providing feedback may provide opportunities for your team to improve. So after the first 5 years of this data collecting and benchmarking, they put a number of processes in place when they identified a major cause of postoperative mortality, as indicated by low cardiac output state and heart failure that was being under-recognized by their team. And you can see there was a significant drop after that intake phase after the first 5 years, where there was a 10% reduction in mortality following isolated coronary bypass grafting. You can see over time that with iterative changes and going back and looking at the data, finding new opportunities for improvement, these curves continue to separate. So the blue curve indicates the expected mortality, again, indicative of the older, sicker patient population that we're all dealing with. And the red line indicating the actual observed mortality over that period of time by using quality improvement initiatives such as phase of care mortality analysis and others to identify where the risk is occurring and then putting processes in place to minimize it. This can be done in the areas of blood product transfusion in terms of, and other factors that are important in terms of improving quality in the post-operative patient, as shown for these number of publications for you here, not just in the Northern England group, but also in Michigan, Virginia, and other jurisdictions, Maryland, and other jurisdictions around the United States. One of the metrics that came out through one of these analyses thereafter came from the Virginia group, where they looked at the mortality following a catastrophic event leading to deaths. And so this is termed as failure to rescue, or the scenario in which a mortality occurs potentially due to a modifiable complication. In this case, they looked specifically at cardiac arrest. And so when looking at cardiac arrest within their regional consortium, they found there was a high rate of mortality following cardiac surgery, arrest after cardiac surgery, but also a lot of variability between the 17 centers that were reporting within that group. And so when you looked at this as a whole, there was a number of lives lost over the 10-year period that was analyzed, equivalent to about a plane crash per year. And there were certainly some higher versus lower performing centers. And so by using this data, identifying that cardiac arrest after cardiac surgery was an important quality metric or failure to rescue, using the high versus low performing centers, they could share information and best practices to hopefully move the ball for everybody forward and decreasing that variance between centers, which is one of the quality principles that both Schuhart and Deming have advocated for a number of years ago. So again, using some technology and processes put in place by Mr. Dunning for resuscitation of cardiac surgery patients, they've sought to implement this in their healthcare system to see if it improves outcomes with failure to rescue within their group. Again, I think everyone's aware of this protocol, so I won't belabor this, but you know there is some time and investment that has to go into educating your teams to do this. And this is the type of scale that's often required to have an impressive or impactful change when a major deficiency in your healthcare system is identified through the phase of care mortality analysis or identification of risk factors for failure to rescue. Okay. That's pretty long. Let me stop there, and I'm happy to take more questions during the discussion period, but I'll summarize here. This is a slide, again, that I've taken shamelessly from Alan Menkes, which is a really good indication of how there are natural limitations to human performance. And we're increasingly working in complex systems with complex patients. A tendency is to look for new tools to help monitor, such as echocardiography, which is of value. I don't want to minimize its importance, or other monitoring tools to help goal-directed therapy and so forth, all of which, again, have value. But those tools in of itself are not necessarily good enough to overcome limitations of human performance. In other words, newer technology does not eliminate error. The human factor is still an important component, and we need to develop processes for identifying when these vulnerabilities occur as part of patient care and what we can do as part of it. The first step is identifying you have a problem and then looking for which patients are at risk. But then you really need to drill down to where the actual component of the patient journey needs to be targeted first. Using phase of care mortality analysis and the failure to rescue metrics have the potential to improve outcomes, as shown by the Michigan group and the Virginia group in the past. The perioperative course is really an interconnected sequence of events that go all the way from the preoperative phase to point of discharge. That's a combination of clinical events, decision-making, the interventions that you provide, and the treatment responses when patients are not doing well after surgery all lead to potentially negative outcomes. And while we look to often point fingers at someone where an error may have occurred, in the vast majority of cases, it's not an individual person that's to blame. It's really the systems in place that have allowed a vulnerability to slip through that has impacted your patients. With there, I'll stop and I'm happy to take more questions during the discussion period. Thanks very much for the opportunity to talk to you today.
Great. Well, thank you very much for that talk. Very clear and instructive. As we sort of have a little bit of time, we can move on, and we'll have a lot more time therefore for question and answers. Our next speaker, I think, doesn't need any real introduction. He is Mr. Euroscore himself, Sam Nasher.
Hello. Umberto kindly asked me to address the question as to whether Euroscore is still the best model. So the answer is yes. Thank you for your attention, and I'll happily take questions. No, but seriously, why do we need a risk model? Well, it's for two main reasons. The first one is to help guide treatment decisions so that both doctors and patients can make good decisions based on some sort of idea of what the likely outcome of the treatment will be. And the second, somewhat unrelated, but equally important, and that is to help assess the quality of care. And we do this by comparing the predicted outcome of a group of operations versus the actual outcome of what actually happened after these operations. Now, when it comes to guiding treatment decisions, Euroscore and all other risk models are not predictive. They simply do not predict. In fact, every single risk model will get it wrong every single time for an individual patient. Because say, for example, the model predicts a mortality of 5% for a particular operation in a particular patient, that patient will afterwards either be alive or dead. And there is nobody who is 95% alive and nobody who is 5% dead. Models cannot predict that. And if a model was able to predict survival with zero error, i.e. tell you who will live and who will die, then nobody would ever die after an operation, because we simply wouldn't operate on them if we know in advance that they're going to die. However, despite these limitations, if you are a patient contemplating an operation and you know that in a similar group of patients with a similar risk profile, having that particular operation, the model says mortality would have been about 5%, then that in itself is very useful information to help both the patient and the doctor make a decision whether to go ahead. So in order to achieve reasonably good predictions like this, we need two things. The first one is we need good calibration. We need the model to predict a percent mortality in a group of patients, which is not that far from the actual mortality. And Euroscore Euroscore 2 has remained very well calibrated since it was launched more than 9 years ago. But we know with progress and time, this is not likely to last. The second thing we need is good discrimination. That means if a model says patient A is higher risk than patient B, then we should have patient A more likely to achieve a poor outcome than patient B when we take these pairs of patients and repeat the analysis across the entire data set. And Euroscore 2 has regularly achieved areas under the ROC curve of over 0.8, which in other words means very good discrimination. So it has achieved both calibration and discrimination well and consistently over the last 9 years. This is the discrimination curve for Euroscore 2, and the straight line is effectively a guess, throwing the dice to find out what's going to happen, and the thick dark line is what Euroscore 2 actually achieves. When it comes to assessing the quality of care, all models can suffer from a number of limitations. The first one is that no model includes every possible risk factor. So some risk factors will be left out. Secondly, sometimes there is variability amongst observers in terms of interpreting data when it comes to risk information. And this is especially true where the risk data are partly or wholly subjective. The other problems that can beset risk models are inaccurate data entry, people entering wrong stuff into the system, and perhaps the rather nastier deliberate gaming of the system that sometimes takes place in order to make people's outcomes look better. Now, when it comes to Euroscore 2, there is no doubt that it does not include all the possible risk factors. In fact, the number of risk factors we use in Euroscore 2 is relatively limited, between 17 and 20 items of information. But we have to remember that if we have additional risk factors, this is not without its problems. Firstly, because it can affect the stability of the model. Secondly, because there are many risk factors out there which are simply not available. The information about them is not available for all patients in all institutions. And last but not least is that it does make the risk assessment much more time consuming. I remember an interview of Rossi of Status Quo, the famous rock band, who were often criticized for just using 3 chords in their songs. And he was asked, why don't you use more chords in your songs? And he said, well, what do you want? Do you want us to have 100 hit songs that people can enjoy done with 3 chords? Or do you want us to have just 3 hit songs, each done with 100 chords? And in a way, Euroscore has 20 risk factors, but has 20 million users, as opposed to the possibility of having 20 million risk factors, but only 20 users. Euroscore 2 also has relatively limited inter-observer variability, mainly because it uses risk factors that are as objective as possible, but without losing any of the crucial fields that we know have got a clinical impact on outcome. And like all models, it cannot do anything about inaccurate data entry or deliberate gaming. Now, despite all of that, we can definitely improve on Euroscore 2. The first thing is to add risk factors which are increasingly being recognized as important, such as frailty. And our eyes are open to this. And once there is a rapid, universal, and consistent method of assessment that is used fairly widely, then we would incorporate frailty into Euroscore. And the second is there is already some limited assessment of the interaction between risk factors and Euroscore, but that assessment is not comprehensive enough. And I think we can improve on that quite a lot, but in order to achieve that, we need a much larger data set. And finally, it would be good to have a way for continually monitoring and tweaking the calibration so that we don't have to launch massive data collection exercises every 2 years as we have done in the past. So some of you might be pleased to know that Euroscore 3 is now on its way. We will launch the project later this year, hopefully towards the middle of the year. And we aim to collect data continuously this time. That means you will not have to be entering single individual cases into the data system, but the system will accept total files of data. And this will ensure a number of things. One of them is perpetual development and evolution of the model without massive data collection exercises. It will also mean that the data set will be continually growing, and as it grows, it allows for far better and thorough analysis of interactions. If you think your hospital or unit would be interested in joining us in this venture, just drop me an email, say who you are and which unit you work for, and we will take it from there when we're ready to start collecting data. In the meantime, Euroscore remains an objective model. It is built on solid data. It is currently well calibrated. It has very good discrimination. And there is no doubt that it is very easy to use and has been accepted across the world. To have a good risk model, you need to use data fields that are as objective as possible, widely available, and clinically credible. That means the clinicians trust them as things that have to do with outcome. And the data fields must be selected to ensure that the model remains robust and stable. There should be enough risk factors for good discrimination, but not so many that we put users off using it. And like most surgical decisions, the model really should strike the right balance between what is feasible and what is sensible. So is Euroscore still the best risk model? Yes, but I'm the first to admit that it is not perfect. However, we are constantly working on improving it. And finally, I would like to say that we have no monopoly on risk assessment. And I really mean this. We welcome the development of other models which may be better, whether they are for global cardiac surgery or for subsets of procedures or for subsets of patients. And if you have an interest in this and you would like to take this sort of study further, please be my guest, and I wish you all the best of luck. Thank you for your attention.
I would like to thank all the speakers, and I would like to welcome our president, Simon Kendall. Thanks for joining this session, Simon. May I start with a question for Sam and Rumana? We all know that socioeconomic factors are really important, as strong predictors of operative mortality. Actually, sometimes the socioeconomic background is more important than age, diabetes. And my first question for Rumana and Sam is why, both in the UK, where we have standardized ways to collect socioeconomic status, and also more widely for the Euroscore, why such an important factor has not been accounted in the current risk prediction? Thank you. I think, Rumana, you may need to unmute.
I don't think I should be answering this question, really. It should be the people who are collecting the data and inputting the data, I think.
Sam says, Sam, I think you should unmute. There is a blue button on the where you can unmute. There are
Okay.
2 blue circles with video and.
We can hear you, Sam.
I thought you could hear me. Yeah.
We can hear you.
Now we can, yeah.
Okay, good. I'm pretty sure I was unmuted. Anyway,
The answer to this is simple. It's because we made a model that's for use worldwide, and the collection of socioeconomic data is very highly variable between countries. And I'm not entirely sure that we would be able to find a single description of what socioeconomic status is that's applicable to all countries. And in the similar way, we did not include race, for example, which is also known to have an impact on health outcomes, again, because many countries simply do not collect those data. Like I said before, you have to be selective when it comes to risk factors, and pragmatism is a large part of that selection.
Thank you.
There's a couple of questions from the floor here. First one from Sunil Badia. Question again for Sam. Will Euroscore have machine learning?
Yes, we've actually done this before. We did artificial neural networks on Euroscore 1, and it produced a tiny improvement in discrimination, which really was not worth the effort, to be honest. It was not significant. The difference was not significant, but it was a positive difference. As we get more and more data with Euroscore 3, I hope that we will be able to repeat that exercise and see if machine learning is one way of going forward. We don't have to use logistic regression. There are lots of ways of doing it. And neural networks, which can learn from AI, are definitely one way of doing it. But I reckon we will need an awful lot more data before we can look into it again.
And going along the lines, another question for you again, Sam, is from David Jenkins. He says, is a universal risk model in cardiac surgery an outdated concept? And should we have separate models for CABG, aortic, mitral, and other types of surgery?
Yes, that is definitely one way of looking at it. And in fact, the STS model does that. The STS has got several categories, and some patients that don't fit into any category, so you can't calculate the risk for them. I think it's probably a question of choice. If you're interested in the most accurate assessment for a particular patient in front of you with a particular operation for which you have loads and loads of data, then yes, subset-specific model is better. If you're interested in assessing the quality of care generally, I think a general model is probably better. One of the problems with assessment of quality of care is the issue of category shift, in that the surgeon does actually have some sort of control as to which category their patient falls into. And they can choose what they do when they're scrubbed to locate patients in certain categories. And as soon as you move on to procedure-specific data rather than overall data, it provides surgeons, I'm sorry to say, with lots of loopholes by which they can make their results look better. So my preference remains for a global risk model. But yeah, I can see the point that if you can have more precise risk assessment for subsets of patients. That one of the interesting things is the number of papers I'm asked to review where people say, we tested Euroscore on 63-and-a-half-year-old women having aortic valve replacement first time with no concomitant procedure and a good ventricle, and we found it doesn't discriminate. Well, you've just taken away all its ability to discriminate. So you always lose a bit when you go into very specific subset risk modeling. I'm not quite sure where the ideal balance should lie.
Okay. I've just got one question for Professor Omar, because it's come up a number of times with people who sent me emails. Can you explain the actual solid line, between the observed, the predicted, and the risk-adjusted plots on the random effects model, and where the black solid line crosses the national average? I have a terrible time trying to explain that, what that actually means to people.
So you wanted me to explain the actual which one did you want me to explain? All the points there, or?
No, well, no. On the forest plot itself,
yeah,
we have the 3 points, and then there's a solid black line that goes through them, and it changes in length depending on the unit and the individual. We just want to know what that solid line represents.
Oh, okay, the solid line. Yeah. Okay,
Yeah.
the solid line, I mean, that is the sort of, that measures the variability that you are willing to accept, basically. So if I want to describe it in statistical terms, it's the confidence limit of the random effects, really. So you have you allow the models to have random intercepts. So you're adding the UIs, which are called random effects. And these UIs are estimated from the data, and these are the confidence intervals for the UI, which gives us variability that we kind of expect. However, in the plot, we transform it into probability, and there is a kind of an indirect transformation that's going on. So basically, the way you can explain is that is the level. Shall we say that is the level of variation that we would be happy to accept. But if that variation does not include the vertical line, then obviously it's gone beyond the acceptable level of variation. That is what it is. So the length doesn't indicate any level of precision or anything like that. Just variation. Variation for the unit.
Simon, and then there are some other questions from the audience coming through as well now.
Great talks, thank you. And Sam, I remember doing that first 1994-95 Euroscore one survey with the paper form, so I'm just a huge fan of what you've achieved. I've got a question for all of you, in that the cardiosurgical audit has taken years of refinement for me. It's like a Formula One car, and we've just made it finely tuned. And then the pandemic comes along. And have you got any feel for us, any observations of the effect of COVID on the risk, the denominator? You know, what are your warnings to us?
It's going to get worse. I think mortality is going to go up for a number of reasons. Firstly, because many patients we operate on may have had COVID and may have had some damage as a result. Many patients we have already operated on have actually been found in the early phase to be suffering from COVID, and they got operations and did really, really badly. I'm sure that's been the experience in many centers. And then finally, a lot of the pent-up demand, which has been suppressed because people have been reluctant to come to hospital, is now opening up, and many of these patients are in a far worse state than they would have been if we had operated on in a more timely fashion. So I think mortality is going to go up, and probably risk-adjusted mortality too.
And also, sorry, no, I was just mentioning your presentation, and at least for my experience, human error during the pandemic, may have been higher, because the team has been clearly deployed to other areas. I think Rakesh, if you can comment, thank you.
Yeah, thank you. So that's a really important point. So just to go back to Simon's first point in terms of what Sam had spoken to as well, we're going to see people present later in their disease course will be the first problem. So we're operating people on a higher risk than perhaps they would have been 2 or 3 months if they haven't been deferred as such. By way of example, we've seen more type A dissections in the first 5 months of this year than we typically see in a whole year. So people seeking primary care optimization as through the door to get referred to a cardiologist and a cardiac surgeon has been delayed. And then because of slowdowns as a result, there has been now an increased backlog of cases that, even though we are used to waitlist in Canada, they certainly have been extended across the nation. The second point that you brought up then with regards to the impact to the healthcare team, independent of errors, which will happen for sure, the psychological ramifications is bringing most of our healthcare teams to their knees with what we're seeing. That will have long-term effects independent of errors that will certainly occur when you have nurses redeployed to areas that they're not usually familiar with, which again, we're seeing here, and I'm sure many of you are as well. It's impossible to implement quality improvement initiatives in that time. We've tried over the past 8-9 months, and we've been able to stamp out some fires, but certainly there'll be a lot of lessons learned from this of using mixed teams with varying degrees of experience with a cardiac patient in the post-operative phase.
Thank you. Thank you.
We've got a question from Danny Keenan saying, will Euroscore 3 talk to advanced analysis tools as we've heard about today? So I presume linking in with POCMA or failure to rescue models, I assume.
Well, these are all different methods of quality assessment. They obviously do link with each other because you do need the risk assessment in order to evaluate point of care mortality analysis and to evaluate all sorts of other outcomes. I mean, in a way, in my mind, they are already linked, but Rakesh's ideas are fantastic, I think, for looking at failure to rescue and looking at unexpected outcomes. And there are other analyses such as fiasco and ARC analyses, which might be much more sensitive than mortality to detect system and human problems. And I think we should all begin to develop an interest in carrying out these analyses in our own hospitals, because there is a lot of benefit to be gained. Mortality is probably it's a good thing that mortality has reduced so much, largely due to all of this robust monitoring, but it may not be good enough to pick things up. And Rakesh and his teams in intensive care can almost get almost any kind of wreckage we throw at them to survive. So you need to find a slightly more sensitive way of picking up where things go wrong.
Okay. A couple more points about Euroscore 3. Should intraoperative risk factors be incorporated into the future model, and will hepatic dysfunction be included in the new model?
Well, you know, I'll answer the second one first. We tried hepatic dysfunction. We actually looked for blood tests. And those of you who participated in Euroscore 2 will know that we were asking for ways of assessing hepatic dysfunction. And we're told that the best and the most sensitive is going to be albumin, serum albumin. And we looked at that, and it just did not cut the mustard. It didn't work. So maybe it was the wrong one to choose. Maybe we should have gone for something simpler. But if you use complex liver assessment as a way of assessing liver function in cardiac surgical patients, you're going to find that for the vast majority of patients, the data are not there. So we really need something very simple. Somebody suggested INR might be a good one, but INR is no good if you're taking warfarin, and bilirubin is subject to all sorts of distortions. So we keep it in mind, but we recognize that it's going to be a difficult one to do. And as far as intraoperative measures, that I don't think is for a preoperative risk model. That is really more for ICQ models such as ICNARC. I mean, things that happen in the operating theater are, in my opinion, part of the outcome rather than part of the risk measure.
I suppose one comment I want to understand is with the POCMA and the failure to rescue model, in order to do a sort of analysis, does that mean, you know, the way the groups have done it in North America, do you need to work as a group of units to sort of sit down and look at that, because then you can look at the variation between units to actually give you the learning you want? Or can an isolated unit just be doing the POCMA analysis on its own in the hope to sort of find something and deal with that problem?
So I think so. And I've learned from people like Len Whitman at Johns Hopkins University and elsewhere, where they've implemented this as part of their regular mortality and morbidity rounds. And so I think it could be done both at a micro and a macro scale. So yes, it does require a team. It requires an interdisciplinary team to look at the various phases and provide their perspectives on what category the patient may best fit into. And then between sites, there may be opportunities to learn about high versus lower performing centers, about the particular sentinel events that may be common. Every center will have slight nuances, but big things like failure to rescue or preoperative frailty evaluation, or how one monitors bleeding in the postoperative phase, or discharge planning may be common amongst a number of centers, where you can identify that minimum core set to analyze and find ways to improve upon.
Another question from the floor is, should we take in the quality of the coronary arteries in our risk stratification models? I presume syntax or something like that nowadays.
Yeah, I think we could do, but it's really difficult, and that is one example of something that can be very subjective.
Okay.
So, Uday, can I ask?
Yes, sorry, Simon.
The questions are interesting, aren't they? Because they are seeking absolute perfection, and I would observe we've done mortality to death, and you know, the risk models are good, but do our presenters today think it's time to move on a little, or are you enjoying the risk models so much that you think we should just keep pursuing perfection?
So I'll jump in first, because I know Sam's already provided the mic drop at the beginning of his talk saying Euroscore 2 is the best, so I don't want to try to supersede that. But I'm a strong proponent of this concept, and where I find the phase of care mortality analysis to be most interesting is how then we scale it towards enhancing recovery. And mortality is important, but the morbidity and what happens to people following hospital discharge is probably equally, if not more important to the patient. If they're unable to go back to their own home or can't remember who their grandkids are, at the end of the day, that's probably more impactful if they live or die. I think people care if they live or die. We're finding models where we can use preoperative evaluation and perioperative care to better predict those who will thrive versus those who just survive, I think is what we need to move towards. It's my personal bias.
I'll agree with that fully. I think there is no doubt that we need to have a robust handle on mortality. And I think by and large, in Canada, in Europe, in Australia, this is done. This is achieved. Now, we should continue doing it, but we don't need to be fussing too much about it because it actually works. But that is not the only measure of quality of care. There are so many other measures. Many hospitals have now started looking at morbidity analysis. It's still in its infancy, but it's getting there. And the definitions of complications is becoming better. And then I'm going to I'll mention 4 things, okay? POCMA, which you heard about today, which I think is definitely worth looking at in terms of identifying problems that may not be picked up by mortality. Number 2, fiasco analyses, which is where you look at poor outcomes in low-risk patients, because relatively limited amount of investigation can, by looking at the patients who really should not have died but did, can give you lots of information about any system errors that are inherent in your own institution, but perhaps nowhere else. The third one is ARC. It's acute risk changes, where a patient goes to the operating theater with a Euroscore of 5 and arrives to the ICU with an intensive care risk prediction of 20 or 25% that this patient is going to die. Now, that tells you something happened in that operation. And these are definitely worth analyzing because they will, again, identify both human errors and system errors. And the final one, sorry, in response to Rajesh, which is looking at quality of life afterwards, believe it or not, there is almost no decent study that looks at quality of life after cardiac surgery. So it is quite possible that we are operating on many patients and doing them nothing but harm. Yeah, they survived, but what kind of survival is it? So you might be pleased to know that the QUACS study, this does not refer to the charlatan nature of surgeons. It's quality after cardiac surgery study is now running in the UK. We've recruited over 1,000 patients. We need another 7,000, and we hope that at the end of that, we will be able to identify those patients who are extremely unlikely to gain either in terms of survival or in terms of quality of life, and who should therefore not be harmed by heart operations. So if your unit is participating, fantastic. If it isn't, then you please join us. I think we got about 80% of the units in the UK on board.
Great. It's interesting then, because I'm sure many trusts within the UK are globally introducing this structured sort of judgment review that the Royal College of Physicians has brought out as a means of of mortality and examining and improving a process. Do you think it's applicable to surgery, and particularly cardiac surgery?
I'm not sure what you mean by that today.
Well, it's just it's something that's, you know, at least within our trust, you know, we're being asked to look at mortality under that kind of process, which is looking at a process starting from pre-operative through all the care, MDT meetings, and all the sorts of processes you would perhaps see in a pathway. But it's interesting. It's come out of the Royal College of Physicians, and it's about sort of death, and risk assessment isn't one of the biggest things physicians do, unlike us.
Yeah. My gut feeling is that we're probably further ahead on mortality assessment and evaluation than the physicians.
Okay. There's only one comment from David, who I think is written in reference to the COVID. He thinks there are likely to be poorer outcomes, as the panel have already said, for the reasons of being fewer procedures, and those who are operated on will be much further in their journeys with higher risk scores. So.
And can I ask Rakesh, Uday? One of the things I observe in this country is it's the surgeon who thinks that he or she's taking the risk, and not the patient. What's it like in Canada?
So I wish I could say it's different, but that brings up the other point I think that Sam brought up in his, is the idea of frailty. And I think what we need also from risk models is something that can incorporate information for shared decision making. So some of the work been done at Halifax with Ken Rockwood with his clinical frailty score, and then Greg Hirsch in developing easy to use tools for patients to understand what risks are as part of that shared decision making, something we need to work on in general, I think, within our specialty or in surgery in general, particularly ones that incorporate issues such as frailty that will impact post-operative functional capacity. So I'm quite keen on looking at that in more detail. We don't, unfortunately, do it better here than in most cases. We have implemented here a few years ago these complex case rounds where we do have patients who are deemed to be higher risk based on, again, a pre-op frailty score or other factors. We do meet as an interdisciplinary team to discuss a limited number of cases with cardiology and the cardiac surgeon, as well as the intensive care and anesthesia teams. But it still doesn't involve the patient or their family as part of that discussion. And I think that's something that we should probably as a specialty move towards, is really trying to inform patients and involve them as part of the decision-making process a bit more comprehensively.
Okay, great. I'm told we've come to the end of our session. I'd like to thank all the speakers for all the time they put in. Yeah. It's a lot of work, and all the videos have been very good, very clear, and the message went on. I'd like to thank all the attendees for their input and their questions. So I'll leave you all to go and visit the exhibition, the virtual exhibition and everything else, and catch up with you later on in the meeting.
Thank you. Good luck with the quiz at 6 o'clock.
Okay.
Thank you, Ramona. Thank you, Rakesh.
Thank you.